So let's switch to the last case. So Ajay, I want you to present a patient that's relapse refractory.
Sure. 65-year-old female diagnosed 4 years ago with stage 2 myeloma. She did have translocation 1416. She had a great CR after RVD induction followed by transplant. Did not go on Len maintenance. And then on routine follow-up, she now has fatigue, but's working full-time, has grade 1 neuropathy. M-spike is now 1.4. Light chains are rising. She's anemic with a hemoglobin of 10.3 and has a creatinine of 1.3.
So when do you start therapy for this relapse disease?
I think this is a really interesting question because clinical trials are probably way overrepresented with biochemical progressors, and you get these great numbers. And then what I've seen in real world is, on the one hand, duration of therapy is much shorter, but the time to next therapy is much longer. And I think what's happening is in the community, people aren't treating that M spike of 0.5, right, which we can put somebody on study. And so I think it depends on the patient. Obviously, if it's a rapid rate of rise, even if it's low, I might start early. If it's a high-risk patient, I might start early. If it's somebody that has had bone disease, I might start early because I don't want to risk that. Conversely, if it's low rise, biochemical, no history of bone disease, low-risk patient, I might wait a little longer.
Would you do it differently, Nina?
Definitely, if they had a history of renal insufficiency in the past due to their myeloma burden, I would do it on a biochemical progression. I just feel like those guys get into trouble early, and definitely a little bit earlier, I've seen sometimes with the relapse disease. So that's one case where I would be more prone to use the numbers. I also agree with Ajay. I think the reason I like to use numbers is because it gives me a hard point. I think, okay, this clinical trial was done with the progressive disease history, and this person meets a progressive disease, so I'm going to have the same results as this clinical trial did. I think that in my head, obviously knowing that we don't do the same in clinical trials. But it's a fine line because what do we usually do? We say, oh, let's repeat your labs and you come back. And if that's still going up, I think 0.5, 0.7, 0.9, that's a time to change. But if there's an absolute value difference of 1.0 in the M protein or 200 on serial on the light chain, that absolute value for sure. Beyond progression, that's beyond progression now, I would treat that.
Would you do it differently, Alpha?
No, I agree with all the considerations. I think you need to consider the pace of rise, the prior complications that the patient had, where they are with their numbers relative to where they were when they were symptomatic. But I think somebody who was in a CR and we watched the M spike go up to 1.4, I would treat this patient.
So I agree with that.